Second morning session. Dr. Gore has a quick announcement to make before we launch into immunotherapy.
Sorry, I apologize. I meant to inject a plug into my talk, but as part of this user-centered design process, we try to get input from patients as we go through the development of the tool. And there's a gentleman outside named Sean Miklas at the table right out here who has a sign up if you're interested in giving us your input on the quality of life on the quality of life tracker tool. So if you're interested in giving us input in the current state of the tool before we launch in a month, Sean Miklas is right outside with the sign up, and we'll contact you to schedule an appointment. Thank you very much.
Okay, so we're going to move into the second session, which really is a highlight focusing on some of the latest advances in immunotherapy. So how many of you saw the movie Fantastic Voyage many, many years ago? So as a kid, that was probably my first introduction in retrospect to immune therapy. If you remember Raquel Welch. I'm surprised, Stan, you don't use that image in your talks. Everybody wanted to be an antibody attacking Raquel Welch at that moment. So anyway, so this session focuses on immunotherapy, and our first speaker is Dr. Mike Schweitzer, who's a medical oncologist that we recruited a little more than a year ago from Johns Hopkins University. You may remember his talk last year focusing on testosterone therapy, this bipolar androgen idea, which that trial is now open and underway at the University of Washington. Today he's going to give us an introduction on immune therapy. Mike?
All right, thanks, Pete. I guess I'm the token clinician in a room full of immunologists today. But I was going to talk about, I guess, cancer immunotherapy, and specifically just go over some Immunology 101. This is a very large topic, so I'm going to give sort of a whirlwind tour of it, and hopefully I do it some justice. And then at the end, I was also going to touch on therapeutic cancer vaccines. So I think the way I think about the immune system's fundamental job is that it's really there to recognize things that don't belong in our body and to eliminate them. And so oftentimes we think of this as being pathogens, things like bacteria or virally infected cells, but this can also refer to cancer cells. And so I think central to the ability of the immune system to actually recognize something as being foreign and eliminating it is that it has to be able to differentiate between what a normal-looking cell looks like and what a cancer cell looks like. So, for instance, say we have a normal-looking prostate cell here. He's friendly enough. He has normal proteins on his surface. The immune system's matured in his presence, so he knows that he's a friend, and that when he sees a cell that has proteins that look like this on its surface, these are things that he can leave alone. In this context, we usually refer to these proteins as antigens. There are a lot of ways that the immune system can recognize normal versus foreign-appearing cells, but antigen recognition is one of the important ones, so I'm going to focus on that just for a second because I'll bring it up later on as well. But this normal cell can actually transform, usually through some mutation event, into an angry form of itself. This is a prostate cancer cell that looks distinctly different from the normal prostate cell. So he may actually have some of the same antigens as the cell he was derived from, but he probably also has some abnormal antigens on his surface too. And these are abnormal because they were encoded for by this mutated DNA, so they're distinct from the normal cell. And this is one of the ways that the immune system can recognize cells as being normal, cells that they should leave alone, versus cells that are from, say, a cancer or another infectious agent. And so when we think about the role that the immune system plays in trying to control cancer, this is just one hypothesized way that this occurs. And so this is called the immune editing hypothesis. And it basically lays out three phases by which the immune system interacts with a cancer. And so on the far left, there's the first phase, the elimination phase. This is when the cancer is first developed. The tumor cells are represented by the green and the blue hexagons. At this stage, the immune system immediately recognizes it as being the enemy. They rush to its site and they work furiously to try to kill off the tumor cells. If they're not able to completely eliminate the cancer cells, an equilibrium can be struck, whereby it's essentially a stalemate between the tumor cells and the immune system. And this can go on for some time. Eventually, if the tumor does progress, though, we call this the escape phase. And this is when the immune system is really no longer effective in controlling the cancer. And this is the phase when we feel like the immune system really has failed to do its job appropriately and keep the tumor under control. And so I think one of the central questions of immunotherapies is how do we reverse this process? Can we take cells that have escaped immune surveillance or come up with new strategies to try to get the immune system to re-engage those tumor cells and eliminate them again? And so just to take a step back and talk a little bit about immunology basics, I did want to briefly touch upon just the two main branches of the immune system. So there are two main branches, the innate and the adaptive immune system. The innate immune system is just like the name would have you think. It's what you're born with. These are sort of like the first responders to a foreign appearing cell. It's relatively rapid, occurs within a matter of hours to days, but it is short-lived. This isn't the branch of the immune system that results in long-term immunity, and it's also not specific. The immune cells in the innate immune system really react to foreign-appearing cells in a more generic way. They recognize general patterns that would have you realize that the cell is abnormal, but it's not going to be specific for one type of cell, for one type of cancer cell or one type of viral cell, et cetera. The adaptive immune system is the other branch of the immune system, and this is relatively slow to respond compared to the innate immune system, usually over the order of a few days. But this can result in long-lasting immunity, and importantly, it's also relatively specific. So the main cells of the adaptive immune system are T and B cells, and they both have specificity for one or maybe a few antigens, and that allows them to really target just one type of cell that we think needs to be cleared. These two branches are not completely independent of one another. There is some crosstalk between them, and one of the important roles that the innate immune system plays is actually in activating the adaptive immune system. And so I did want to spend just, I guess, one more minute talking about the adaptive immune system, because this is the branch of the immune system that most immunotherapies are really geared towards activating. And so, again, there are two cell types, T and B cells. Regarding T cells, these are during the first couple decades of life, people generate probably on the order of tens to hundreds of millions of unique T cells. These T cells each have unique receptors on their surface, represented by the green here. And these receptors are really specific for a single antigen. At this stage, when these T cells are sort of surveilling the bloodstream or in the lymphatic system, they're really not activated. They're not able to do what they're intended to do and actually eliminate these foreign appearing cells. They have to become activated, and one of the important ways that these T cells become activated is that they engage with their antigen. And so one of the cells from the innate immune system, or a class of cells, the antigen-presenting cells, one of its main jobs is to actually show this T cell the antigen that it's specific for. Once this interaction happens, when the antigen is exposed to the T cell that it was meant to link up with, these cells start to proliferate, and they actually change into a number of different cell types. The cytotoxic T cell is probably the one that does most of the work in actually killing off the abnormal appearing cells. But there are a number of other subtypes which we can talk about later if people are interested. B cells are pretty similar to T cells in regard to the fact that they are rather specific. Before they're activated, they also have a B cell receptor on their surface, and the activation of this population of B cells really is predicated on them also engaging with their antigen. So in this case, you have a T cell actually showing the B cell its antigen, but once it's exposed to the antigen specific for, these cells will differentiate into a few different cell types. One of them, plasma cells, are sort of like mini factories that make antibodies. And so once these plasma cells have started revving up, they're going to churn out a specific antibody. All these antibodies are identical, and they're specific for one antigen. And so you can imagine if you have a cancer cell that has had a B cell respond to its antigen, it's going to generate all these antibodies, which are then going to go out and bind to any cell that expresses those antigen. They're going to coat it, and once it's coated with antibodies, it's basically going to be tagged for destruction, and it'll end up getting killed through a number of different variety of mechanisms. And so there are a lot of immunotherapeutic strategies, and we're going to hear about a few of these later on in separate talks, but I was asked to talk a little bit about cancer vaccines specifically. So when we talk about cancer vaccines, we're usually referring to therapeutic vaccines. So these are vaccines that are intended to treat cancer, not vaccines that are intended to prevent it, although there are some vaccines that probably do that as well, like the HPV vaccine, for instance. And most of these cancer vaccines, the way they function is really to expose the immune system to antigens that are on cancer cells, to allow the immune system to see that antigen and hopefully generate a response that's going to result in the immune cells going out and killing off tumor cells that express those antigens. And so there are a number of different strategies. There's viral-based vaccines like ProstVac-VF. There's dendritic cell vaccines like Provenge or Sipuleucel T. There are DNA vaccines, and there are other types as well, but I wanted to just touch on these briefly. So I know this is a complicated figure, but I did want to just walk through it step by step because I think it highlights how a viral-based vaccine works. And I highlight the ProstVac-VF vaccine because there's actually some pretty encouraging data with this vaccine that it can perhaps prolong life. That was shown in a small study, and there's currently a much larger trial which we hope to have a readout on in the next year or so. But it's possible that you might hear more about this drug in the future if that larger study comes back positive as well. But the way these viral-based vaccines work is generally that DNA that's in a little loop, we call that plasmid DNA, encodes for a couple of different proteins. So it encodes for PSA, which is a prostate antigen, and then encodes for 3 other proteins in the case of ProstVac-VF, which basically work to stimulate the immune system. This little plasmid of DNA is inserted into 2 different types of viruses, a vaccinia and a fowlpox virus. And then these 2 viruses that are loaded up with this DNA, that's what ProstVac-VF is. So patients get the ProstVac-VF, this loaded virus basically, and then once it's in their system, it goes on to infect normal cells. So the ProstVac-VF, this virus that's loaded with this DNA is going to infect normal epithelial cells. These cells are going to start making the proteins that are encoded for by the DNA. They're going to make PSA and they're going to make these other immune stimulatory proteins. Eventually these cells die, but they're going to release all those proteins they just made. These proteins then get taken up by these antigen-presenting cells, and then they take those proteins and they present them to T cells. These T cells then now have met up with the antigen they were destined to bind with, and they start dividing, turning into cytotoxic T cells and going out and destroying cancer. And so that's generally how a viral-based vaccine works, and this is specifically for the ProstVac-VF. The next one I wanted to talk about was Sipuleucel T, or Provenge, because this is actually the only therapeutic vaccine that's approved for any cancer right now, at least in the US. And so the way this works is that a patient undergoes what we call leukapheresis, so they actually remove a volume of blood and they spin it off and they harvest just the white blood cells, the immune cells. These immune cells, and specifically the antigen-presenting cells, are basically incubated for 36 hours with a protein, where half of the protein is PAP, which is an antigen on prostate and prostate cancer cells, and GM-CSF, which is a protein that stimulates the immune system. After that 36-hour period, these cells are given back to the patient, and this whole process goes on for a total of 3 treatments, each spaced out by 2 weeks, and that entire course is what we would consider a round of Provenge. But after these cells are infused, you have these antigen-presenting cells that are now primed to basically present this PAP antigen to T cells, and similar to ProstVac-VF, these T cells become activated, and then they go out and kill off tumor cells. One of the sort of perplexing things about Provenge, about Sipuleucel T, is that in all the studies, it doesn't look like it actually shrinks tumors. It doesn't look like it decreases PSA levels. But the phase 3 study and even a phase 2 study showed that it improved overall survival, and that's why it was approved. These 2 points seem a little bit discordant with one another, but I think there may be an explanation for how Sipuleucel T is able to actually effectively prolong someone's life, but not actually lower their PSA or shrink a tumor. And so this is a graph that's depicting basically a tumor's growth over time. So if you do nothing, it's going to grow, and it'll keep growing if you don't intervene at some point. Conversely, if at that same point you were to treat another patient with Provenge, you might actually be able to flatten the rate at which the tumor is growing. So you've changed the kinetics of how fast this tumor is growing. And if you imagine that the 2 dashed lines represent the lower and upper bound of sort of what type of difference you'd be able to see in the growth of a tumor, you actually gain a considerable amount of time between these two scenarios, so that the guy who's had his growth kinetics flattened so that the tumors aren't growing as fast will actually have gained a lot of time compared to the person who didn't get Sipuleucel T. This is a theory. We haven't really proved this in the case of Provenge, but this is one of the explanations for how it might actually result in prolonged survival, but not necessarily cause tumors to shrink or PSAs to decline. So Provenge, again, I think it does have some efficacy, and it's certainly appropriate for some patients, but I think there's definitely opportunities to try to improve upon the efficacy of Provenge. And so this is a clinical trial that we have ongoing here at the SCCA that's looking at taking patients who have been treated with Provenge and then randomizing them 50-50 between either just observation or another drug called IL-7. IL-7 is a protein that naturally occurs in all of us, and one of its main jobs is really to stimulate T cells. So the idea is that if Sipuleucel T can generate a T cell response, if you follow that up with IL-7, it might make that response that much better, and hopefully that translates into better responses to the drug. The main point of this study is really to look at these T cell responses specifically, and that's what we're looking out for. But I think if that looks promising, a future trial would perhaps look to see if this strategy is superior in terms of efficacy to just Sipuleucel T alone. The last type of vaccine that I wanted to talk about was DNA vaccines. And I apologize for this crude schematic. I couldn't find a pretty one on the internet, so I kind of patched this one together. But the DNA vaccine, it basically just involves injecting little plasmids of DNA directly into the muscle. And so this specific one, INO-5150, is one that we're testing here, and it uses two plasmids actually. One of them encodes for the protein PSA, which again is a prostate-specific protein, and the other one encodes for PSMA, which is another protein that's commonly found on prostate and prostate cancers. So these two plasmids are put in a syringe, they're injected into the muscle. Once they're injected, we actually use an electroporation device, which gives a small electrical current around the site of the injection. And what that does is it opens up the muscle cells so that they can take up this plasmid DNA. And once the muscle cells have taken up this DNA, they're going to start making the proteins that it encodes for. So these muscle cells eventually die, but after being injected with this INO-5150, they're going to release a bunch of antigens that are prostate-specific. And just like Prosvac and just like Sipuleucel T, these antigens are going to be recognized by the immune system. You're going to get T cells that are going to be generated and probably B cell responses too. And so this is just the general schematic for the clinical trial we have going on now looking at this drug. This is specifically for guys who have biochemically recurrent prostate cancer. And what that means is they've gone through some local therapy like had a surgery or had radiation, but their PSA is rising. We don't see any cancer on scans, but because the PSA is going up, we worry that the cancer cells might be lurking around somewhere. And so we take those patients and we treat them with basically escalating doses of this INO-5150 vaccine, and then some of the men also get an additional DNA vaccine that encodes for IL-12. IL-12 is another protein that helps to stimulate T cell responses. And so the end point of this study is really looking at safety, because this is a very early study and we have to make sure the strategy is safe first. But it's also going to look at some of the T cell and B cell responses to see if there is a signal that this actually works to do what we hope it's doing. So there was a lot of information all at once, and I'm sure we can talk more about it during the Q&A, but just to summarize, the immune system has the ability to recognize cancer cells and to clear it, and there's a lot of evidence supporting that. Tumors can undergo a number of adaptive changes that ultimately allow them to circumvent the destruction by immune cells. And then I think on a fundamental level, I think immunotherapies are really seeking to revitalize the anti-tumor immune response. And there are a lot of ways to do this. I talked about vaccines, but I think we'll hear about some other newer methods that are being explored here. So.
Thanks, Mike, for that great introduction to this area, and I know you're going to get a lot of questions in the Q&A period. So we're very fortunate to have with us this morning truly one of the world's leaders in immunotherapy, Dr. Stan Riddell. So Dr. Riddell is a member of the Clinical Research Division here at Fred Hutch and also a professor of medicine at the University of Washington. His career really has focused on understanding immune responses originally around bone marrow transplant or stem cell transplantation, but he's been responsible for some of the leading advances in these engineered T cells. And you may remember not too long ago that Vice President Biden visited us here at the center, and it was really because of Dr. Riddell and his team's work around T-cell therapy, I think that really sparked Vice President Biden's interest. So, Stan, it'd be great to hear from you. Thanks.
Thanks very much, Pete, and it's a real pleasure to actually have the opportunity to talk with you. I don't work on prostate cancer, although Pete's sort of gradually trying to rope me in. But my work has largely been in blood cancers, although we are increasingly starting to think about how we can use some of the approaches that we've taken to treat epithelial-type cancers and solid tumors. I'm sort of a bit of a history buff, which is maybe why one of the reasons I remember Raquel Welch. But there are other reasons. There are other important historical landmarks in immunotherapy. And I was always intrigued by Paul Ehrlich's comments, which were made more than 100 years ago. And what he said was, and this you have to understand, this was at a time when we didn't even know there were T cells and B cells that Dr. Schweitzer just talked about. And what he said then was, I'm convinced that during development and growth, malignant cells arise extremely frequently, but in the majority of people, they remain latent due to the protective action of the host. So what he was really saying is that we all get cancer quite often, but we just never know it because our immune system takes care of it. But he went on to say, when this is where you realize that some of these guys were so bright and they really essentially told us what we should be working on 100 years ago. But he said, I'm also convinced that this natural immunity is not due to the presence of antimicrobial bodies, and what he meant there was antibodies, which had been discovered at that time, but is determined purely by cellular factors. These may be weakened in old age where cancer is more prevalent. Already, again, in those days, recognizing that aging was a major risk factor for cancer development, but also telling us that perhaps cells of the immune system were involved in controlling cancer development and potentially controlling cancer progression. So Dr. Schweitzer gave you a good introduction into T cells, and I'm going to talk about one of the cellular elements that we think is really critical to treating cancers with immunotherapy. And what he told you was that T cells develop in the bone marrow, and they're educated in an organ in our chest called the thymus. And that education process they undergo in the thymus tells them select cells that have receptors that don't see self-antigens. So those little beacons that Dr. Schweitzer talked about that are on our normal cells, you're selected to have a T cell repertoire that won't see those. And you only have T cells that come out into the periphery that actually can see foreign antigens or foreign molecules. So if a cell gets infected with a virus, now the proteins from that virus are expressed in the cell, and they're displayed on the cell surface, and you have T cells that have receptors that can, just like Velcro, stick onto those foreign antigens and recognize them. And maybe one of the reasons that these cancer vaccines that target things like PSMA, PSA are not so effective is those are self-antigens, and the repertoire of T cells is culled for cells that have receptors that really have high specificity for the antigen. But if we think about cancers, cancers result from mutations in genes that encode proteins that regulate cell survival and growth. So when you have a cancer, it's growing because it has mutations, and it's accumulating more mutations as it grows. And these mutations result in changes in the protein sequence. And we know for some cancers, like lung cancer, where a mutant KRAS molecule, a single one amino acid change in KRAS drives the proliferation of those cells. And in melanoma, there's a mutation, again, a single point mutation, one amino acid change in a protein sequence that drives the growth of that melanoma. So those mutations could potentially be sensed by the immune system. And many cancers that have lots of mutations, you might imagine that you could get a T cell response to them. So from the T cell's perspective, cancer is non-self. Now that sort of gives immunologists and immunotherapists great hope, because now from the perspective of the immune system, cancer can look like a virus. So I want to just go through some results now, because now we have the capacity to sequence genomes. And actually, it's people like Dr. Nelson that really drove the technology to tell us that we ought to be doing this. And what we've learned from doing that, and this is sort of a graph of the number of mutations based on a certain stretch of DNA in a cell. And you'll see that cancers that are out here, well, maybe out there, things like melanoma, lung cancer, where they're result from UV light exposure or cigarette smoking, so carcinogens that increase mutations. These cancers have lots of mutations. Prostate cancer, just for perspective, is sort of in the middle here. Now, from the standpoint of the immune system, in fact, you would suspect that these cancers, which you've notoriously thought are terrible cancers, they don't respond to chemotherapy, those should be more non-self because they have more mutations. And in fact, that's exactly what's turning out to be true, is that these are the cancers that respond to these antibodies that block immune checkpoints that allows T cells in the microenvironment to actually see the tumor and destroy the tumor. And so cancers that were historically very, very bad are now turning out to be those that are susceptible to immunotherapy. But, of course, not all cancers respond. And the reason for that is that, as Dr. Schweitzer sort of briefly alluded to, the tumor microenvironment is actually very complicated. As these cancers grow, if they're so non-selfish, why is the immune system not eliminating them? So sometimes it does, and when we don't know we had a cancer, but sometimes it doesn't. And when we start to look at these different tumor microenvironments, we're starting to understand that they're all different. That in fact sometimes there are many T cells in the microenvironment, but they're suppressed by regulatory molecules that we can now block and allow these cells to eradicate the tumor. But in other times the tumor itself excludes the T cells from getting in there. And we have to find ways of getting the T cells into these tumors. So my lab has been focused for a while on asking the question, can these cancers down here, low mutation burden cancers, be targeted with T cells? And for that we realized we would have to take a very different strategy. And we focused on leukemias and lymphomas because they're really down here at the bottom of the tail. And we had to say, are there ways that we can use our own ingenuity to try and engineer T cells to see these cancer cells? And so what we did is we took advantage of the fact that B cells, so those are the ones that cause a B cell leukemia or a B cell lymphoma, they all express a molecule called CD19. Now this is on normal B cells as well, but it's also on all the cancer cells. And it's only on B cells, so it's not on other normal cells in your body. And so what we decided to do is to say, could we create now a receptor that we could introduce into a T cell and engineer that T cell to kill B cell cancers? And the way that we did that was you can make antibodies to a molecule. So for example, if you have a human CD19 molecule, you can immunize a mouse and make an antibody that's specific for that molecule. And you can then take the sequences of that antibody that are the Velcro that bind to the CD19, and you can engineer that into the T cell receptor signaling molecules. And so what you've done is essentially use synthetic biology now. So this is sort of fantastic voyage to create essentially a new receptor that could target the cancer cell. And if you put a little green fluorescent tag on that receptor, you can see if you put it into a T cell, it expresses quite nicely around the surface of the cell. And if you put it into a tumor cell, it forms this beautiful synapse, this kiss of death, and will destroy the tumor cell. So the other thing that we've done at the Hutchinson Center is we realized that if we're going to engineer T cells with these receptors, not all T cells are the same. And Dr. Schweitzer briefly alluded to this, but in order for T cells to actually work, they have to be able to go into the patient. They have to be able to grow faster than the cancer and kill all the cancer cells. And they have to be able to migrate to every place in the body where the cancer is. And they have to be able to last long enough to eliminate the cancer cells. And so my lab's been studying the various types of T cells and have really realized that there are subsets of cells that are likely to be much more effective for this genetic engineering approach. So what I sort of tell people is what you don't want to do is design these beautiful, elegant receptors that will target cancer cells and then put them into essentially a Yugo to do the job. So what we've done is shown that, in fact, if you pick the right cells and formulate them in the right composition, this is a B-cell lymphoma growing in a mouse, and it's got a luciferase gene in it, so you can image tumor growth, and you can see that you can devise very highly potent formulations that will completely cure these mice. And so we've now actually taken this to patients, and I want to go through just a little bit of patient data. This is work that's done by David Maloney and Cameron Turtle, and there was an article in the Seattle Times earlier this week on our first publication on this work. But we're essentially taking patients with leukemia and lymphoma that have failed all other treatments. So they failed all the chemotherapy regimens. They've often failed a bone marrow transplant. We take these patients and we isolate their T cells. We formulate a defined composition product, and we're giving them cell doses. We have to do a dose escalation trial to find out what the optimal cell dose is, but for many patients, the optimal cell dose is this. I don't know if you can see this here, but that's a grain of rice. So we're treating cancer, and I will show you some of the images where the lymph nodes are massive. They're 10, 12, 14 centimeters with a number of T cells that's equivalent to that. And that's because this is a living therapy. It can go into the body, it can proliferate as it sees the cancer, and gradually eliminate it. So just to show you, in the acute leukemia trial, we've treated now 31 patients. 27 of 29 patients that have been evaluable have got a complete remission.